Dr. Emilly Neves Souza. Am I right?
I am here, yes.
Yeah. Welcome, doctor. She will be presenting her experience on the importance of a dermatological examination in patients with exclusively aesthetic complaints. Definitely, yes. We generally miss out other examination, other dermatological concerns. We always run behind the aesthetic issues, but this is very important to take care of other dermatological part. Yes, I would like to hand over the floor to you, Doctor. She is from Universidade de Sao Paulo, Brazil. Yes, the floor is yours, Dr. Emilly. Yeah.
Can you see my screen?
Yes, doctor. We are able to see and we are able to hear you. The floor is yours.
Okay. Hello, everyone. I'm glad for the opportunity to be here with you today. I'm Emily. I'm a dermatologist and fellow in trichology in Brazil, and I'm here to talk about hair transplantation in cicatricial alopecias. What do you know so far? When we think about hair loss, we know that it can be a distressful condition to our patients. It affects up to 85% of male patients and up to 40% of female. And the most common cause is androgenetic alopecia. We know that hair transplantation has been widely used to restore the self-esteem in our patients and promote a more youthful appearance for those ones troubled by baldness. We have basically two most popular techniques today, follicular unit transplantation, the FUT technique, and follicular unit extraction, FUE technique. The FUE technique is the most common technique because it has a better healing and less scars and pain when compared to the FUT technique, but it also has a longer operative time. We have seen a lot of famous actors taking care of their baldness with hair transplantation, such as Jude Law, as we can see here, and also John Travolta. And how can we select the patient to perform hair transplantation? First, the main diagnosis used to indicate hair transplantation is androgenetic alopecia, but here I brought the discussion about cicatricial alopecias as well. The patient must be up to 25 years old. We must select the hair caliber because larger hair shafts provide better coverage. And the ideal donor hair density is up to 80 follicular units per square. We must also classify the degree and pattern of baldness before indicate the hair transplantation. We know that light hair color provides a discrete coverage, and we must clarify patients' expectations to avoid deceptions after surgery. And can we indicate hair transplantation in cicatricial alopecias to recover scalp flaws? Cicatricial alopecia are defined by permanent hair loss in the scaled area and are classified as primary cicatricial alopecias and secondary cicatricial alopecias. Regarding primary cicatricial alopecias, we know that the most common are frontal fibrosing alopecia, cutaneous lupus, lichen planopilaris, central centrifugal cicatricial alopecia, folliculitis decalvans, and dissecting cellulitis. Hair transplantation in primary cicatricial alopecias still is a therapeutic dilemma because the surgical procedure can exacerbate the inflammatory infiltrate in the hair follicle and result in worsening of the alopecia. So hair transplantation can be planned only after complete disease stability, and sometimes it is never achieved. And there are still no clear guidelines regarding its implementation. But we know that these patients have a huge negative impact in quality of life, and they deserve an opportunity to restore their self-esteem. We see in this picture here a woman with an extensive frontal fibrosing alopecia And if we can offer her an opportunity to improve her appearance, we need to do that. Regarding secondary cicatricial alopecias, we know that burns and surgical and traumatic scars are the most common causes. When the patient has localized scars, we know that we can provide an excellent outcome with hair transplantation, such as illustrated here in the beard of these patients 1 year after hair transplantation. But when the patient has extensive scarring, the improvement of scarring areas is hard to achieve, mainly in burns and post-radiation patients. We can see here a young woman with chemical burn after scalp bleach treatment in a hair salon, leaving this extensive scalp area, scarring area. And what are the challenges associated to the hair transplantation in cicatricial alopecias? First, we must have alopecia stability up to 2 years. The vascularity of scar tissue is variable and unpredictable, and graft survival and wound healing are unpredictable. When we think about the disease relapse, it is possible due to Koebner phenomenon, mainly in lichen planopilaris and frontal fibrosis in alopecia, and it can result in loss of the grafted follicular units. The extensive scarring may have donor area insufficiency, and usually multiple sessions are required for a good cosmetic outcome. It is possible that these patients can have future association with androgenetic alopecia along the years, and we have to think about all the complications associated with this surgery, such as hypertrophic scars, graft rejection, infection, relapse of alopecia, corkscrew hair, and low density. And when we decide to do the hair transplantation, how can we plan it? First, we have to analyze the donor recipient area. To estimate the donor recipient area is the most critical decision in choosing hair transplantation for cicatricial alopecia, because in the majority of the patients, the available donor follicular units are insufficient to treat the extensive scar. We also must analyze the scar texture, because a lot of patients have atrophic scars or hypertrophic tissues. The location of the scars is also important. And when we think about scar vascularity, we know that the vascularity of the alopecia area is already compromised due to scarring, so we must avoid adrenaline usage. And regarding the alopecia, we must maintain its treatment during and after the hair transplantation, so we can maintain topical and oral treatment to avoid disease activity. There are some articles about attest grafting in the recipient area before the full surgery. It is necessary because we can do this test in a specific area and wait 6 months to assess the outcome. When we know if we know that we can activate the cicatricial alopecia. So if we try this test grafting before the whole surgery, we can suppose what we can expect after the surgery. So here is an image that showing a test site of follicular unit grafting, and an amazing outcome and better response of the patient. When we think about density of follicular units, it is also a difficult decision, but we know that the chosen density to perform here must be lower when compared to androgenetic alopecia, because we have here areas with poor blood supply. So in these areas, we must use lower follicular unit densities, and areas with good blood supply, we can use a little higher follicular unit densities. And as I said before, more than one session is usually necessary to cover all the scarring area. Vascularity tends to increase following the first surgery, so this is a good news. And we should do hair transplantation in stages. A second surgery must be performed 9 to 12 months after the first surgery. And when we think about technique, we can do alopecia or scar reduction, that there is a surgery only to perform the reduction of the scar, excision and suture. We can do the FUE technique, choosing follicular units to implant in this area, or we can do the strip follicular transplantation, when we do the transplantation of a linear part of the scalp, and the patient will have a linear scar and also pain and discomfort after surgery. Here we can see a central centrifugal cicatricial alopecia before and 2 years after hair transplantation with a good response. And a little summary of surgical tips. We must use less bulky grafts with less epidermal component for a better accommodation of the follicular units in the scarring tissue. Larger and deeper slits can use in thick fibrous scars, and smaller and deeper slits in lax scars. As I said before, we must use low graft density packing. Automatic handling of grafts is important because we don't want to induce a Quebner phenomenon. And we must promote a good post-operative care regarding the alopecia as well, and maintain its treatment after the surgery. Here we can see a cicatricial alopecia before and one after hair transplantation in the eyebrow with a good result. Some adjuvant treatments that are found in the literature, we can use topical minoxidil before and after surgery to increase local blood supply and prolong an adjuvant phase. Pentoxifylline can also be used prior to surgery to increase the oxygenation in the recipient area. Intralesional steroid injection and topical corticosteroids can be used to reduce the scarring area thickness and increase the pliability. Fractional lasers and Erbium-YAG lasers can be performed before the surgery to reduce thickness in hypertrophic scars and improve the outcome of the grafting in cicatricial alopecias. And some articles are telling us about platelet-rich plasma. Its use can be performed before, during, and after surgery. PRP influences wound healing and scar remodeling and may provide a better survival of follicular units. And what we can expect after surgery. We already know that hair transplantation has a low graft survival rates when comparing to non-scarring alopecias, and good outcome is already reported in central centrifugal cicatricial alopecia, lupus erythematosus, frontal fibrosing alopecia, folliculitis decalvans, and other cicatricial alopecias. But some articles already shows us a decrease of graft survival over time. We see here an image of a coupe de Sabry lesion before hair transplantation, and the same patient 12 months after the transplantation, with a good survival rate of follicular units. Von Galvan in 2019 published a study of frontal fibrosing alopecia after hair transplantation with 51 patients. These patients underwent hair transplantation with a mean time stabilization of disease of 15 months, and they used mostly the strip technique in the majority of patients and FUE technique in a lower group. And they reported a mean graft survival rate of 87% in the first year. Sure, it is a good survival rate, but when they analyzed the patients after 5 years, only 12 patients remain in the study. They noticed that less of 60% of follicular unit survival rate was, they observed that. So we know that this patient here showing the baseline of frontal fibrosing alopecia 1 year after her transplantation, she presented an amazing survival rate of follicular units, and 5 years after her transplantation, we can see the decrease of survival rate of follicular units to 50%. It is a huge rate of loss of follicular units, and we must talk about it with the patient before the surgery to avoid some sessions here. And here are my references. Thank you for your time. Here's my information if you want to discuss more about this topic and follow my work. Thank you.
Thank you, Dr. Emilly. It was nice hearing you. Definitely, it's very difficult to have a good outcome in cicatricial alopecia. Fortunately, I'm also a hair transplant surgeon from Nepal. Yeah, it was very interesting for me. I generally also do this thing like prick with the needle and see for the blood flow, whether the scar is completely without blood or with some blood over the area for the better graft survival before choosing those patients for in cicatricial alopecia before hair transplantation. And definitely it's a very risky job because again, there can be a risk of polymerization as you have rightly mentioned. So
Yes.
yeah, is there any question for Dr. Emilly? If not, then let's move to the other presenter. Thank you, doctor, for your